Hello, good morning, everyone.
Good morning, ma'am.
Okay, we'll start now. Okay, so 92 of the students are here. Shall we wait or shall we start?
We can start.
Okay, we'll start then. Okay, for today we have diseases of aorta. Okay, so aorta, it is the conduct through which the blood circulates to the peripheral circulation from the heart. Okay, so there are different disorders of aorta. Okay, so the important one we'll be discussing. Okay, today aortic aneurysm, aortic dissection, aortitis, and coarctation of aorta. Firstly, regarding aortic aneurysm. First of all, you have to know what is aneurysm. Okay, so aneurysm, it is a pathological dilatation of a segment of blood vessel, and it depending on the involvement of the layers of the vessel. Okay, so it can be true aneurysm involving all the three layers, pseudo aneurysm involving the outer layer only, or adventitia only. Okay, and depending on the basis of segment of circumference involved, it may be fusiform aneurysm involving entire of the circumference of the blood vessel, and saccular aneurysm, which involves only a part of it. Okay, so this is the diagram showing normal blood vessel. You can see the intima, media, and adventitia. Okay, so if it is true aneurysm, then there will be dilatation, but there will be involvement of all three layers. Okay, so this is true aneurysm. And if it is false aneurysm, okay, so you can see that only adventitia, it gets involved in the dilated segment. So this is the difference between the true and the false aneurysm. Okay, now saccular and fusiform aneurysm. As we have said, okay, so if the partial circumference of the vessel is involved, it causes saccular aneurysm. And if entire circumference of the vessel is involved, then it causes fusiform aneurysm. So these are under true aneurysm. And as we've said, false aneurysm, it involves the dilated segment of the blood vessel involves only the adventitia. Okay, so media and intima, there won't be any involvement in the dilated portion. So this was in general about the different terms that we use when you are talking about aneurysm. Okay, so now we'll be focusing more on the aortic aneurysm. So aneurysm in the aorta, that is the aortic aneurysm. Okay, so abnormal dilatation of the lumen of the aorta, it causes aortic aneurysm. Okay, so depending on the location of aneurysm, whether it is in the abdominal aorta or thoracic aorta, okay, so it can be divided into abdominal aortic aneurysm and thoracic aortic aneurysm. So this is again the diagram showing the same. This is the diaphragm. This is the aortic arch, ascending aorta, okay, and this is descending aorta. Below this, this is the abdominal aorta. So abdominal aortic aneurysm means there will be dilatation of the abdominal aorta, and thoracic aneurysm involves dilatation of the thoracic aorta. Okay. So what are the causes of aortic aneurysm then? Most of the time, it may be degenerative, age-related, okay, so related to cigarette smoking, hypercholesterolemia, hypertension, atherosclerosis, okay. So elderly patients who are smokers, who have dyslipidemia, who are hypertensive, and who are atherosclerotic, okay. So these are the patients who may be prone to degenerative causes of aortic aneurysm. And sometimes there can be some genetic or developmental anomalies. Okay, this leads to this aortic aneurysm. Okay, so most of the time it may be related to Marfan's syndrome. Okay, Marfan's syndrome and Loeys-Dietz syndrome. Loeys disease syndrome, it is much more related to Marfan syndrome. Okay, most of the clinical features they will be similar in these two. And Ehlers-Danlos syndrome. Okay, so it is related to weakness of the connective tissue, including weakness of the tendons and ligaments. Okay, so if the patient has this Ehlers-Danlos syndrome, then there will be very loose joints and skin will be very much thin. Okay, so this will be the abnormality that we get in these patients. And sometimes this aortic aneurysm, it may be associated with Turner syndrome, familial problems, and bicuspid aortic valve. Okay, so it may be a result of chronic aortic dissection. It may be a result of aortitis. Okay, so inflammation of the aorta because of Takayasu's arthritis and giant cell arthritis, and infective, like in cases of syphilis, tuberculosis, and mycotic aneurysm. Okay, so this term mycotic aneurysm, mycotic means fungal. But this is a misnomer. Okay, so it is generally caused by infection because of different bacteria to the blood vessel, and sometimes it may be because of fungus as well. And the other rare cause includes trauma to the aorta. Okay, so what are the clinical features in a patient who has aortic aneurysm? Okay, it depends on the site of aneurysm, where the aneurysm is. Okay, so if it involves the thoracic abdominal aorta, the clinical features will be different. If it involves abdominal aorta, then the clinical features will be different. If it involves the thoracic aorta, then there will be acute severe chest pain. The patient may present with features of aortic regurgitation. Okay, so aortic regurgitation, yeah. The patient may present with high pulse pressure. The patient may present with bounding pulse, okay, dancing carotid, okay, and sometimes they may also present with features of congestive heart failure. Okay, so it is generally as a result of aneurysm of the ascending thoracic aorta. Okay, and there can be compressive symptoms as well. Okay, so if there is compression to the trachea and the bronchus, the patient may present with stridor. If there is hoarseness, then we have to suspect compression to the recurrent laryngeal nerve. And sometimes, because of mass effect, there can be superior vena cava syndrome as well, where the patient presents with dilated veins and swelling just above the neck region. Okay, and sometimes if there is erosion of the esophagus and the bronchus, okay, the patient may also present with massive pain. So the clinical presentation, it may be very diverse. Now, if the patient has abdominal aortic aneurysm, okay, it can be found incidentally on physical examination, plain X-ray, or most commonly abdominal ultrasound. Okay, so even the large abdominal aortic aneurysm can be difficult to feel, so many remains undetected until they rupture. Okay, studies are currently underway to determine whether screening reduces the number of deaths for rupture. Okay. And the patient, so as we've said, there can be incidental finding when we are doing the examination or when we are investigating the patient. But if the patient has symptoms, okay, the patient may present with pain. So pain, it is mainly in the central abdomen, back, loin, iliac fossa, or sometimes in groin. Okay. And some of the patients, they may also present with thromboembolic complications. Okay. So it may be because of thrombus within the aneurysm sac, which gets dislodged to the lower limb. And less commonly, the aorta may also undergo thrombotic occlusion. Okay? And similarly, as in cases of thoracic aortic aneurysm, okay, there can be some features because of compression. Okay? So surrounding structures such as duodenum, if there is compression to the duodenum, there can be obstruction and vomiting. Okay? And the patient may present with features of intestinal obstruction. And if there is compression over the inferior vena cava, the patient may also present with edema and deep vein thrombosis. And sometimes there can be presentation with rupture. Okay, so rupture into the retroperitoneum and the peritoneal cavity of the surrounding structure. So most commonly rupture of the inferior vena cava leading to aortic cable fistula. Okay, so this may be the presentation of the clinical features in patient who has thoracic as well as abdominal aortic aneurysm. So what are the investigations that are important? Okay, so first thing we do is chest X-ray where we can see widening of the mediastinum and displacement or compression of the trachea or the left main bronchus. Okay, so echocardiography, it can be done for visualization of the proximal ascending and descending thoracic aorta. Okay, so this is the echocardiography of a patient showing widening of the mediastinum. Okay, so you can see widened mediastinum. Now, ultrasonography, it is the best way for establishing the diagnosis of abdominal aneurysm. And it is also important for follow-up in patients who do not have any symptoms and who are not yet the candidate for surgical repair. Okay, so if the patient does not have symptom and if the patient does not have large aneurysm, large enough for the surgery. Okay, so we have to follow the patient, screen the patient frequently doing this ultrasonography. The other investigation is CT thorax. Okay, so it provides more accurate information about the size and extent of aneurysm, the surrounding structures, and presence of any other intra-abdominal pathology. So it is not only to see the size and extent of aneurysm, but it is also to see for the complications, invasion, and compression of the other intra-abdominal pathologies. Okay, and it is the standard preoperative investigation but is not suitable for surveillance. Okay, so because it is very costly, it is not used for surveillance, but it is generally done preoperatively. Now, management. Okay, so the medical management, if aneurysm is secondary to Marfan syndrome, beta blockers decrease the rate of dilatation and risk of rupture. Okay, so except for beta blockers as well. Okay, so there are other antihypertensive drugs like ACE inhibitors, ARBs, calcium channel blockers. These are the additional medical therapy that are indicated in patients who are still hypertensive with beta blocker. Okay, and the surgical management includes open repair of the aneurysm or endovascular aneurysm repair. Okay, so what are the indications for surgical management? Okay, so um, to all the patients, we have to give medical management. Okay, so we have to control the blood pressure using the antihypertensive drugs, mainly the beta blockers, ARBs, ACE inhibitors, calcium channel blockers. But in some patients, okay, surgical management is very important. Okay, so who are the candidates who require this surgical management? Okay, so for the patient who has abdominal aortic aneurysm, if the patient has symptoms, all the patient needs surgical treatment. Okay, so all the patients who have symptom, all the patients with abdominal aortic aneurysm with symptom should be surgically treated. And for the patient who are asymptomatic, okay, surgery is only indicated if the diameter of the abdominal aorta, it is more than 5.5 centimeters. Okay. Okay. And for the thoracic aortic aneurysm, for ascending thoracic aortic aneurysm, if it is secondary to Marfan syndrome or bicuspid aortic valve, surgery should be considered if the size is 4 to 5 centimeter. And for descending thoracic aortic aneurysm, operative repair is recommended if diameter is more than 6 centimeter, and endovascular repair is recommended if the diameter is more than 5.5. Okay, so anyone of you have any problem? I can hear some noise. Anyone has any problem? Okay. Okay, so this is this small video I wanted to show. Let me see if we can see it. Okay, so this is regarding the endovascular aneurysm repair. Okay, so if we can see, it's well and good. Otherwise, it may not be that much important for you.
म्याम हजुरले त के गरेन भन्दैन भिडियोको साउन्डै आएन म्याम
You all the procedure that is said in this video, it's not required. Okay, so the only thing that you have to know is stent graft is introduced. Okay, which is generally introduced via the femoral artery in the groin. Okay, so the main function of the stent graft, it is to prevent the rupture of the aneurysm as well as for the patency of the aorta. You just have to know that. But since it was showing the aortic aneurysm, abdominal aortic aneurysm, and the stent graft, I thought it could be useful for you to understand. That was the main reason why I wanted to show you this slide, this video. Is that okay? Is that okay?
Yes, ma'am. Ma'am, the video ko sound सुनेको थिएन हामीले.
होइन भिडियोको साउन्ड चाहिँ you may not require all the procedure भनेर भनेको okay? So the only thing that you have to know is a stent graft is placed, okay, which is introduced via the femoral artery, okay, and it is mainly for the patency of the aorta and to prevent the rupture of the aortic aneurysm. Pressure कम भयो नि त हैन graft राखेपछि, so it will prevent the rupture of the aneurysm. Okay, so that's all that you have to know. Okay, so all the procedure that is not required. Okay, so now we'll be talking about aortic dissection. Okay, aortic dissection, the incidence, peak incidence is the 6 to 7 decade of life. Okay, and it occurs in younger patients if associated with Marfan syndrome, pregnancy, or trauma. Okay, so men are affected twice as frequently as women, and it is caused by circumferential or less commonly transverse tear of the intima. Okay, so there will be tear of the intima. This leads to the accumulation of blood in between the intima and the media. Okay, so this produces the false lumen within the aorta itself. Okay, so there may be damage to the aortic valve and compression of branches of the aorta. Typically, the false lumen eventually re-enters the true lumen, creating a double barrel aorta, but it may also rupture into the left pleural space or pericardium. Okay, so you can see that this is intima and this is media. In between intima and media you get the blood because of disruption of the intima. Okay, so pathogenesis often caused by spontaneous or iatrogenic tear in the intima of the aorta. Okay? Intima of the aorta, or by primary hemorrhage in the media of the aorta, which then ruptures through the intima into the true lumen that is spontaneous bleeding from the vasa vasorum confined to the aortic wall. Okay, and chronic dissection may lead to aneurysmal dilatation of the aorta, and thoracic aneurysm may be complicated by dissection. Okay. So, what are the risk factors? Most of the risk factors, okay, they are the same. Okay, hypertension, arteriosclerosis, coarctation, genetic like Marfan, Danlos syndrome, fibromuscular dysplasia, previous cardiac surgeries like coronary artery bypass graft, aortic valve replacement, pregnancy, trauma, iatrogenic after some procedure. Okay, so these are the risk factors. Now you have to know about this classification. Okay, so classification, it is important for the planning of the treatment. Okay, so the most important and the simplest one is Stanford classification. Okay, so Stanford classification is, it classifies this aortic dissection anatomically for the management purpose. Okay, so it is classified into type A, which involves the aortic aneurysm, ascending aorta. Okay, aortic aneurysm involving the ascending aorta, and type B sphering the ascending aorta. Okay, so you can see in type B ascending aorta, it is sphered. Okay, so involving the ascending aorta or spearing the ascending aorta. Okay, type 1A and type B. Okay, so in most of the aortic dissection, which are type A, okay, so they also extend into the descending aorta. Sometimes what happens is this dissection, it may extend up to the descending aorta. But even though there is involvement of the descending aorta, it will be type 1. So involvement of the ascending aorta is only the criteria for dividing it into type A and type B. Okay, so this type A, it involves the ascending aorta, and it accounts for 2/3 of the cases of the aortic dissection. Okay, so what are the clinical features? Pain, it is the main feature. If there is involvement of the ascending aorta, the patient may present with anterior chest pain, and involvement of the descending aorta, intrascapular back pain. Pain is typically described as tearing and very abrupt in onset. Some of the patient may also present with hypertension. Okay, and in some patients, BP may drop if there is major hemorrhage. Okay, and when you are examining the pulse, there can be asymmetry of the brachial, carotid, or femoral pulse. Bounding pulse may be there if the patient has aortic regurgitation. And due to the occlusion of different aortic branches, okay, if the coronary branch is occluded. There can be MI if carotid stroke, if spinal paraplegia, if celiac and superior mesenteric infarction with acute abdominal biliary, if there is involvement of the renal artery, renal failure, if the involvement of the leg is there, acute limb ischemia can be there. Okay, so the investigation of choice are CT or MR angiography, both of which are highly specific and sensitive. Okay, so the other investigation is chest X-ray, where we can see the broadening of the upper mediastinum and distortion of the aortic knuckle. Okay, so the area of the aortic knuckle, you may get distorted, and sometimes there can be left-sided pleural effusion as well. And in ECG, the most important finding is left ventricular hypertrophy. And for the echocardiography, we can see the evidence of aortic regurgitation, sometimes dilated aortic root as well. Okay, and we can also see flaps of dissection occasionally. Okay, and most of the time we are doing transthoracic echocardiography, but this provides the image of first 3 to 4 centimeters of ascending aorta only. So the better choice is transesophageal echocardiography. Okay, so transesophageal echocardiography. For the medical management, the aim is to maintain the mean arterial pressure of 60 to 75 millimeter of mercury to reduce the force of ejection of blood from the left ventricle. Drugs used for this purpose includes beta blocker, and sometimes addition of this alpha blocking properties like labetalol can also be used. We can also use rate limiting calcium channel blockers like verapamil and diltiazem if beta blockers are contraindicated, or if it is not controlled with beta blocker. Okay, and sometimes sodium nitroprusside may be considered if these fail to control the blood pressure adequately. So again, continuing the management, the initial management, it comprises of pain management and controlling the blood pressure. For type A dissection, it requires emergency surgery to replace the ascending aorta. And for type B aneurysm, they are treated medically. Okay, so type A means involvement of the ascending aorta. So if there is involvement of the ascending aorta, surgery is indicated. Okay, and if it is type B, if it does not involve the ascending aorta, okay, so it can be medically treated unless there is actual or impending external rupture. So medically treated, but if it has any of the complication, it has to be treated surgically. These complications includes external rupture, vital organ or limb ischemia, as the mortality and morbidity with the surgery in these patients with type B aneurysm, it is very high. Okay, so surgery, open surgery can be done, or interluminal repair can be done. Okay, so it involves either fenestrating or perforating the intimal flap so that blood returns from the falls to the true lumen, and implanting the stent graft as it was done in this endovascular aneurysm repair, okay, plus from the femoral artery. So these are the interluminal repairs. Okay. Now we'll be talking about aortitis. Okay, so aortitis, Takayasu's arteritis, giant cell arteritis, and inflammatory arteritis. Okay, so Takayasu's arteritis. Okay, so it is the inflammatory disease often affecting the ascending aorta, aortic arch, and causing obstruction of the aorta and its main branches. Okay, age of onset, it is 25 to 30 years, and female to male ratio, it is 8:1. So it is more common in female who are young. Okay, so has a worldwide distribution, but most commonly it is found in Asia, and it is characterized by granulomatous inflammation of the vessel wall, leading to occlusion or weakening of the vessel walls. So in patient who has Takayasu's arteritis, okay, what are the clinical features? Most of the patient, they give history of claudication, okay, fever, arthralgia, and weight loss. On examination, there can be loss of pulses, bruise, hypertension, and aortic regurgitation. Okay, and when we are investigating the patient, there may be rise in the acute phase responses, elevation of ESR, elevation of C-reactive protein, and some of this patient may also have normocytic normochronic anemia. Okay, and in angiography, we may be able to see occlusion, aneurysmal dilatation, and coarctation. For the treatment, generally high-dose glucocorticoids are used and immunosuppressants are used. Okay, so this Takayasu's arthritis, giant cell arthritis. Okay, so these are important for your MCQs as well. Okay, so in giant cell arthritis introduction, it is because of granulomatous arthritis that mainly affects the medium and the large size arteries, including the aorta. Okay, so most often it is combined with or associated with poly polymyalgia rheumatica, okay, which presents with asymmetrical immobility associated neck and shoulder pain and stiffness. Average age of onset is 70 years. Again, it is more common in female, 3 times more common in female than in male. And overall prevalence, it is around 20 per 100,000 population in those over the age of 50 years. Okay, the clinical features include constitutional symptom with weight loss, fatigue, malaise, and night sweat. There can be pain, mainly headache will be there, which is usually temporal or occipital, along with scalp tenderness. And jaw pain can be there when the patient is chewing or talking. There can also be visual disturbances. Okay, the patient may have loss of vision in one eye due to the occlusion of the posterior ciliary artery. And fundoscopy, it may be normal initially, but after 24 to 36 hours, there may be appearance of the pale and swollen optic disc with some evidence of hemorrhage as well. Okay? And neurological involvement may occur in the form of transient ischemic attack, brainstem infarct, and hemiparesis. Okay, so these are the features of giant cell arthritis, but if it occurs with polymyalgia rheumatica, there can be stiffness, pain, painful restriction of the shoulder movement on waking as well. Okay, and for the management, okay, so what are the investigations we have to do? Laboratory abnormalities includes elevated ESR and CRP along with normocytic normochronic anemia. 3 important investigations to consider is temporal artery biopsy. Okay, so temporal artery biopsy, it has to be done where we can see the fragmentation of the internal elastic lamina with necrosis of the media in combination with the mixed inflammatory cell infiltrates. Okay, so one important investigation is temporal artery biopsy, and the other one is ultrasonography of the temporal arteries, where we can see the halo sign. Okay, so I'll be showing the halo sign, and the other is 19FDG PET scan. Okay, fluorodeoxyglucose progesterone emission scan. Okay, so halo sign. So when we are doing the ultrasonography of the temporal artery, okay, so this is the artery, okay, and this is the perivascular halo that we get in patient with giant cell arthritis. Okay, so this is called halo sign in cases of giant cell arthritis. These are pathognomic for giant cell arthritis. For the management, steroid, mainly prednisolone, it is given and it should be started as soon as possible if you are suspecting it, so as to prevent the visual loss. Okay, and whenever it is started within 48 to 72 hours of starting the medication, it shows dramatic response with resolution of symptom. Okay, and the dose, it is 60 to 80 mg, and it should be progressively reduced, monitoring the ESR and the CRP, and reaching the dose of around 10 to 15 mg by about 8 weeks. Okay, so it should be very slowly reduced by 1 mg per month, and total duration of treatment, it should be 12 to 24 months. And for advice and prophylaxis against giant cell induced osteoporosis, okay, this oral bisphosphonate and calcium with vitamin D supplement has to be given so as to prevent the osteoporosis. The other one is infective aortitis. Okay, infective aortitis may result from direct invasion of the aortic wall by bacterial pathogens, okay, Staphylococcus, Streptococcus, Salmonella, and sometimes by fungi. Okay, so this bacteria causes aortitis by infecting the aorta at the site of atherosclerotic plaque. Okay, so in the plaque there will be bacterial invasion infecting the aorta. This leads to the saccular aneurysm, and this is called mycotic aneurysm. Okay, so mycotic aneurysm, it has a predilection for the suprarenal aorta. Okay, so this is infective aortitis causing mycotic aneurysm. Now, shortly regarding Marfan's syndrome. Okay, so Marfan syndrome, it is an inherited disorders of connective tissue, and it is often associated with aortic aneurysm and dissection. It is inherited as autosomal dominant manner and affects around 0.02% of the population. And it is caused by protein coding mutation affecting FPN1 gene, which encodes fibrillin and extracellular matrix protein. Okay, and this mutation disrupts the mechanical integrity of the connective tissue. Okay, so what are the clinical features then? So the most serious clinical presentation involving the heart includes aortic dissection and aneurysm, and there can be aortic and mitral valve regurgitation as well. These patients have connective tissue problems, so there can be laxity of the skin and joint hypermobility can be there, abnormalities of the body habitus including long arm, legs and finger, scoliosis, pectus excavatum, and high arch palate can be there. Ocular managed abnormalities can be there in the form of lens dislocation and retinal detachment. Okay, and these are the patients who are more prone for, who are at risk for so the syndrome, very tall guy with ocular problems like lens dislocation, ocular hypertension. Okay, so with dental problems like crowded teeth, high arch palate. Okay, and chest wall deformities, pectus excavatum, carinatum. These are the patients who are at increased risk for pneumothorax. Okay, disproportionately long limbs and long fingers, stretch marks in the abdomen. Okay, disproportionately long legs with flat feet. Okay, so these are the tall, thin build, flexible joints and scoliosis. There can be problem with the heart and the blood vessels. Okay, and there are at risk of pneumothorax. So these are the clinical features in patients with Marfan syndrome. Okay, so for the investigation, genetic testing has to be done. Chest X-ray may reveal evidence of aortic aneurysm or dissection. Echocardiography demonstrates valvular diseases in the form of mitral valve prolapse, mitral regurgitation, or aortic regurgitation. Serial monitoring of the aortic root by echocardiography is generally suggested in these patients so as to plan for the surgery or medical management as well. Okay, management. Beta blockers are used to reduce the blood pressure as well as to reduce the risk of aortic dilatation. Okay, and activities that are associated with increase in cardiac output are best avoided, and surgery are generally done for the replacement of aortic root, which can be performed in a patient who have progressive aortic dilatation. Okay, lastly, regarding coarctation. Okay, so it is narrowing of the lumen of the aorta occurring most commonly distal to the origin of the left subclavian artery. Okay, so this is the left subclavian artery. You can see the narrowing of the lumen of the aorta. Okay, coarctation. It accounts for around 7% of the patient with congenital heart disease. So out of all congenital heart disease, it accounts for around 7% of the patient. It is more common in female and more commonly associated with Turner's syndrome. So if the coarctation, it is very significant. Most of the patients, they present in the early infancy or neonatal period with circulatory shock and renal insufficiency. Some may present with metabolic acidosis. Okay, and if it is less severe, they can be asymptomatic during the infancy period, and in childhood they may present with headache, chest pain, fatigue, and leg leg claudication. Okay, and in elderly they present with hypertension, intracerebral aneurysm rupture, subarachnoid, and intracerebral hemorrhage as well. So, what are the clinical features? To continue, okay, so hypertension will be there in the upper limb, and in the lower limb blood pressure may not be obtainable, okay, and these are the patients who will have radiofemoral delay. Okay, so radiofemoral delay, do you know, anyone remember about radiofemoral delay? Anyone? Anyone remembers about radiofemoral delay? Okay. Sadiksha, do you remember about radiofemoral delay? Sadiksha Chaudhary,
Yes, ma'am.
what is it?
Ma'am, there is the radial and the femoral pulse are not synchronous and they differ, ma'am.
Okay, so this is the important cause of radiofemoral delay. Okay, so along with that, the patient may also have grade 2 to 3 ejection systolic murmur, which is present in the left sternal border, left axilla, and left interscapular region, and sometimes because of the uh, collapses in the intercostal space. Okay, so there can be continuous murmur as well, and it is generally there in the intercostal spaces. Okay, and for the investigation, chest X-ray has to be done, where we can see the dilated left subclavian artery, high on the left mediastinal border, and a dilated ascending aorta. Okay, indentation of the aorta at the site of coarctation will be there with pre and post stenotic dilatation. This is called three side. Okay, so pre and post stenotic dilatation in the aorta, it causes three side. Okay, so this is pathognomic of coarctation. And notching of the third to ninth rib may be there in the chest X-ray. Okay, so ECG, it generally shows left ventricular hypertrophy, but in small there can be evidence of right ventricular hypertrophy as well. Okay, two-dimensional echocardiography with collar flow and Doppler study will also help, and sometimes to see the extent of the disease, CT and MR angiography can also be done. For the treatment, okay, coarctation of this coarctation of aorta, for symptomatic patient who presents in neonate, okay, prostaglandin E1 infusion, it helps to reopen the constricted ductus arteriosus. Okay, so the ductus arteriosus, to make it patent so as to supply to the peripheral circulation. Okay, so this prostaglandin E1 infusion has to be given, and for the hypertension, beta blockers, and sometimes surgical correction or balloon angioplasty is also done. Okay, so do you have any questions?
Excuse me, ma'am.
Any questions? Okay,
Ma'am,
Azur.
के अरे त्यो एओर्टिक डाइसेक्सनको फिगरमा छ नि क्लासिफिकेसनको फिगरमा हजुरले के अरे त्यो फिगरमा टाइप ए को सेकेन्ड फिगरमा असेन्डिङ एओर्टाको मिडल ब्रान्च चाहिँ स्पेयर भएको देखा हो
एकछिन है त कुन भनेको तिमीले भर्खरै अब त्यसमा टाइप ए र टाइप बी भनेर भनेको छ होइन, तर अब त्यसमा चाहिँ डिसेक्सनको भने है,
हजुर हजुर
यो भने
त्यसको
होइन।
हजुर सेकेन्ड टाइप ए को सेकेन्ड फिगरमा एसेन्डिङ एओर्टाको मिडल ब्रान्च चाहिँ स्पेयर छ नि होइन
होइन, यस्तो यस्तो हो कि टाइप ए र टाइप बीमा डिभाइड गरेका छ होइन, तर
हजुर
टाइप ए र टाइप बीलाई डिभाइड गर्ने चाहिँ एसेन्डिङ एओर्टाको इन्भल्भमेन्ट मात्र हो कि डिसेन्डिङ एओर्टा इन्भल्भ हुन पनि सक्छ, नहुन पनि सक्छ।
होइन म्याम, त्यही एसेन्डिङ एओर्टा मै पनि होइन, त्यो मिडल ब्रान्च चाहिँ स्पेयर छ नि, यो फिगरमा देखाएको छ नि, मिडल ब्रान्च चाहिँ स्पेयर भएको के एसेन्डिङ एओर्टाकै तीनटा ब्रान्चमा मिडलवाला चाहिँ स्पेयर भएको देखाएको छ नि
हो, तर इट इज इरेस्पेक्टिभ अफ द डिसेन्डिङ एओर्टा भनेको के
मतलब मिडल ब्रान्च
क्लासिफाई
इन्भल्भ
गर्ने चाहिँ एसेन्डिङ एओर्टाको इन्भल्भमेन्ट मात्र हो, अरू चाहिँ यो डायग्राममा देखाएको भएर हो होइन। तर अब यसमा चाहिँ के देखाएको छ भने अब यसमा चाहिँ यो डिसेक्सनले गर्दाखेरि इफ इट इन्भल्भ्स दि एसेन्डिङ एओर्टा आर्च ओर द डिसेन्डिङ एओर्टा देयर क्यान बी कम्प्रेसन इन डिफरेन्ट ब्रान्चेस भनेर देखाएको हो कि यिनीहरू चाहिँ। यो छ नि यो सबै चाहिँ कम्प्रेसनहरू देखाएको हो कि। यो चाहिँ कम्प्रेसनले गर्दाखेरि चाहिँ अब यसमा लस अफ लेग पल्स रिनल अक्लुजन ओर दि लस अफ आर्म पल्स हुन सक्छ भनेर देखाएको मात्रै हो।
ए हस् म्याम। अनि त्यो रेनल अक्लुजनहरू सबै बाइल्याटरली हुन्छ होइन?
यो चाहिँ यो कम्प्रेसन के रे
त्यो जुन रेनल अक्लुजन मेसेन्ट्रिक अक्लुजन देखाएको छ नि त्यो बाइल्याटरली नै हुन्छ नि है?
अब यस्तो हुन्छ ल, अब यसमा एकापट्टि मात्र इन्भल्भ भएको छ भने युनिल्याटरल पनि हुनसक्छ होइन। अब दुवैतिर इन्भल्भ भएको छ भने बाइल्याटरल पनि हुनसक्छ। त्यस्तो के अरे युनिल्याटरलै हुन्छ बाइल्याटरलै हुन्छ भन्ने हुँदैन।
ए हस् म्याम।
है जहाँ कम्प्रेसन भएको छ त्यसमा चाहिँ त्यो क्लिनिकल फिचर्स डिफर गर्न सक्छ कि। बुझ्यो? अब तर क्लासिफिकेसनमा यो